from the City of Ansonia, and welcome to our special forum with Griffin Hospital tonight. We will be covering topics related to the COVID vaccine as submitted by members of the City of Ansonia and Greater Valley community. I want to thank all those watching this live on Zoom and those watching the recording of this presentation. I would also like to thank the staff and physicians at Griffin Hospital for making themselves available for this tremendous informational opportunity and for the amazing work they have done over the course of the COVID-19 pandemic. Griffin Hospital has been a tremendous resource for so many during this past year, and we are fortunate to have them as our community partner. Now, I would like to introduce our panelists for tonight. With us tonight is Griffin Hospital's President and CEO, Patrick Charmel. Mr. Charmel has been a driving force at Griffin Hospital since 1985, responsible for crafting it into the high-quality facility it is today. Under his leadership, Griffin Hospital has become our state's most trusted COVID testing partner, responsible for providing testing for over 500,000 individuals in our community. We are also thankful to have Dr. Frederick Browne participate in our roundtable discussion. In addition to his role at Griffin Hospital's Chief Medical Officer, Dr. Browne is a board-certified infectious disease physician with more than 2 decades of background and knowledge in the treatment of infectious viruses and vaccinations. Finally, we are joined by Lisa Jafer, the Director of Pharmacy Services at Griffin Hospital, who has been a member of the Griffin family since 2006. Within her role as Director of the Pharmacy, she has helped Griffin Hospital provide COVID testing for over 500,000 of our community friends and neighbors. She is also a member of the committee that has launched Griffin Hospital's COVID-19 vaccination efforts, which has already vaccinated as many of our frontline workers. Now, I will dive into the questions that we have received from the Ansonia and Valley community. Again, I wish to thank everybody who is on this tonight and who contributed for the questions. So I'll get going with the first question, and feel free, panelists, to whoever would like to answer the question. The first one is, this vaccination, is it safe?
Oh, I'm muted.
I think Pat is still muted.
I believe that Dr. Brown is going to take that first question. Sorry about that.
Thank you. So let me sort of, I think it's sort of an interesting question, and I do know of other questions that sort of float along a little bit with this, Mayor. So let me try to roll this into a little bit of a conversation, sort of answer the question about the vaccine itself, and then in turn I'll answer the question about the safety of it, if that's okay with you, Mayor.
Sure.
So interesting enough, I mean, we've been doing vaccines in human history since 1796. So this is one of the first things that we've actually done in medicine that we actually did correctly. There was a lot of things that we did that were not correct, as in, things like bloodletting and other issues that we've had to deal with, the snake oils and et cetera. But Edward Jenner in 1796 was the first person to actually discover if he was able to take a virus, they didn't know it was a virus at the time, but he was able to take a virus which was getting caught by milkmaids, a milk pox virus, was able to take this virus, able to get a little bit of that debris and then inject someone else with it. Then they knew that they would actually prevent that other person from getting smallpox, because they found that these milkmaids we're actually not getting smallpox. And that was sort of the first vaccine. And that's actually relevant to sort of what we're talking about today. So basic modern vaccinations are a variation of that. It's an introduction of a protein or some substance into our body in which we end up developing, the ability to develop antibodies. And I think that's the big question that we're here. So is this safe? Let me talk to you about sort of what has been modified and what's different about this vaccine versus what we've been using in other vaccines. So many years after Edward Jenner, now we're dealing with a vaccine that is using, high levels of science. And the high levels of science are really interesting because as soon as we found out about this virus, and we do this through like most viruses, we know almost immediately the genetic code of it. So we actually can look at that and say, okay, what is that genetic code that we see? And then once we see that genetic code, we can actually say, this is the genetic code, but what does that genetic code do within the virus? And it codes for certain types of proteins. So we know that it codes for certain different types of proteins, and then we know the function of those proteins. What we found on this virus, it actually has all these little spike proteins. And a lot of people have seen the pictures of these little spike proteins throughout the media, et cetera. These little spike proteins are really important in the attachment of this virus to human cells. So what happens is that this virus enters the body, and then these little spike proteins attach to the cells, particularly in the lungs. And then what happens, it releases its genome into the body, and then it tells our body to produce more of these little viron particles. And that's exactly what's happening. So this vaccine, what we've done is we've actually said, okay, we know the genetic code and we know what it does. We can actually synthesize the genetic code. We can then introduce it into the body, and we can actually produce the protein. We've actually been doing this since the early 90s. So in the 1990s, we were actually doing this. We've been using this code to determine different aspects of the body and to produce different aspects in animals and some human models. So it's actually not new, it's just a new vaccine. So what we found is that if we're able to enter this genetic code through a process called messenger RNA, so mRNA, it sends a message to the protein building components of the cells. And when it produces those proteins, it actually releases a protein. In this case, what we do is we actually produce the spike proteins. So we're giving the genetic code that forms the spike proteins. Those spike proteins are then produced. Only the spike proteins are produced, and they actually are released into our body, and our body has an immune response to it. That's actually how this works. So the answer is that right now what we're seeing is that we have these spike proteins, we have a reaction to it, at least an immune response to it, and the next time our body sees the whole component, the big unit, it actually attacks it immediately. So it kind of answers a bunch of questions for you. So right now it looks like, this is what we're using. It's something that we've been using in science for a while. It has minimal side effects, but it produces a significant amount of protein, of the viral protein that our body responds to. So again, the answer to your question and sort of answering other questions is that this is actually a very safe process. It's a process we've been using in laboratories for a really long time. And there's no reason to think that as it produces and continues to produce these spike proteins, that it won't develop antibodies, and then we'll have resistance to the virus when it shows up in our body.
Very good. Very, very interesting. I see the PowerPoint on the screen. Very interesting. I have another question, and it basically comes from me. I have a severe allergy, doctor, to shellfish. And I understand that Moderna's vaccination, it's not good for people who have shellfish allergies. What can you tell me about that? Should people with allergies take the vaccine?
I don't know. Lisa, do you want to?
She's going to unmute herself right now.
Yeah.
There you
Sorry,
go.
guys.
Sure,
Yeah,
no problem.
So from what I understand from all the information that we've seen, and even what the CDC has recommended, is that even people with allergies are candidates for this vaccine. As you've probably read in the media, there have been some allergic reactions, and we see that with almost every medication that we come out with on the market. And when you're giving one medication to as many people as we have just recently, you're expected to see allergic reactions. There is some recommendation if you have a severe anaphylactic reaction. So in other words, if your face swells and you stop breathing, you might want to have a conversation with your physician prior to receiving the vaccine. However, there are no preservatives in this vaccine, and there are no latex in this vaccine as well. And there are very few excipients, if you will. One of them is polyethylene glycol, which is a very common drug or chemical actually that's in a lot of other products, and most people are not allergic to it. Bottom line is it's very safe. Unless you have a severe allergic reaction, it's recommended that you receive the vaccine.
Right. Next question is this is FDA approved, correct?
So let me answer that. So the easy answer is yes, but I think we just need to talk a little bit about the little caveat related to this and some questions that people have. So it is approved, but it's approved under something called Emergency Use Authorization, an EUA. An EUA is actually a new type of process that was developed in 9/11. What happened was in 9/11, there was a disaster that occurred, and the regular processes really weren't fast enough to get important life-saving measures to be put out into the public. And that's really what this was designed to be. So this is designed as a very important public safety and health measure to be put out there. So it is through an emergency use authorization. It's not necessarily to the point where it's fully licensed, because there are some after it's released to continue to monitor the safety of it. But so far it's looking like it's very safe. Now I'm going to expand a little bit on that too. There's been a lot of questions about, this was rapid, we did this very fast, it wasn't safe. That's actually, I think all of those, at least from my personal opinion, is actually not true. So what the difference between what happened with this vaccine versus other vaccines is that typically in the scientific process, we take several steps to develop the vaccine. As we develop the vaccine, we aren't talking about or even expecting it to be produced rapidly. So the production process is not being done at the same time. In this case, we already had the process, we knew it was safe, and as we were finalizing it into human trials and running it through human trials, we were also doing the production aspect of it, which is really important because the safety and the aspect of getting these many people tested, doing controlled trials and figuring out if it is truly safe, is one aspect of it. And that doesn't necessarily take all that much time. It takes about the time that we've seen. The production process, figuring out, how are we going to mass produce this, actually takes sometimes a year, if not years. So this took quite, taking the two and rapidly doing it together. You have the science and the process that are going at the same time. That way you actually have, so that way I can say I feel very comfortable that the science is sound, that we didn't rush to make this vaccine. We actually used top scientific minds in here to say, okay, let's do scientific and engineering minds, because we were doing the genetics and we were doing the process, but then we were also processing it and how do we produce it? And I think that's there. So again, it's an EUA. It's been approved by the FDA, and it will be licensed probably, shortly after, given the amount of vaccine that we've been giving.
Very good. I have a two-part question here. Is it safe for pregnant and breastfeeding women, and is it available for children?
So do you want me to answer that, Fred?
Yes, Lisa, you can take that one.
Thanks.
I'll give you the hard.
So the CDC is recommending that it is safe for women who are pregnant. They definitely are saying it's safe for women who are breastfeeding. However, the recommendation would be if you're a pregnant woman and considering receiving the vaccine, you should speak with your OBGYN about your specific health condition. Secondly, for children, so both vaccines that have been approved right now by the FDA, one is good for 16 years and up, the other is 18 years and older. They are not available for children at this point in time. However, they are doing what's called a bridge clinical trial with children beginning early January to mid-January. And they are indicating that they'll only need to do 2,000 to 4,000 or so children before they'll be able to get approval for use in children. So I would expect, late spring, early summer, that you'll see some more availability of vaccine for the use in children.
Okay. Next question is, will the vaccine protect us if the virus continues to mutate?
So I can answer this one. And the answers to these questions are always, we're always not 100%. But given sort of what I explained before about the spike protein, the spike protein is the major protein that is associated with bringing the material and attaching to our cells and causing infection. There would have to be a major change in the virus to make the vaccine not effective in that aspect. So again, there is always a possibility, but at this point, at least currently, any mutations would not necessarily lead to immediate loss of it. Now, again, there is always some changes, and we're not exactly sure if we're going to have to revaccinate in the next couple years. But right now, I feel pretty comfortable to say that in the immediate setting, the current vaccination is actually going to be good for a good period of time, and then we'll have to figure out if we're going to need to get a booster in the future. But again, I can tell you with confidence that it's going to be effective at least over the next year.
Okay. I have some other questions here. Where can people go to get the vaccine?
Maybe I can take that one, Mayor.
Sure.
We have a few slides. I'll jump to the end.
Sure.
You threw me a curve there, Mayor. I expected that one later, so I have to scroll through.
No problem. I am jumping around all the questions.
That's okay. No, I appreciate that.
Doctors been doing a fantastic job.
They're the best.
Yes, they are.
So maybe we could just talk a little bit about the rollout of the vaccine, and then I can talk about where it's available, if you don't mind.
That's fine.
Because I know there are lots of questions about who and when, and how are those decisions being made?
Right.
So the CDC has an advisory committee called the Advisory Committee on Immunization Practices, and they've made recommendations to the CDC. And those recommendations resulted in the phases that everybody's talking about. That information is made available to each of the states, and the states could adopt those recommendations or modify them. And Connecticut is following those recommendations pretty closely, whereas other states are deviating a little bit. And I just wanted to share some of the thinking that went behind the thinking that went into the establishment of the phases and who's in each group. And it's a very thoughtful process. Obviously, if you're not in the first phase, you may want to question the thinking behind it, but I think it's a very rational approach that I think is very defensible. So there are currently phases 1A, 1B, and 1C, and there's also discussion about subsequent phases. And the subcommittee actually looked at really three domains: the science, the ease of implementation of whatever methodology or approach that they established, and sort of the ethical sort of underpinnings of some of these decisions. So first, in terms of the science, they really looked at who has got the greatest disease burden from COVID-19. And now we've been dealing with COVID-19 across the country since late February and early March. And we can see which populations are getting infected at greater rates, who's got greater mortality and morbidity, and we'll talk about that. And then we want to look at, from a science standpoint, look at the benefits and the harms of vaccination. And that's what Dr. Browne was starting to allude to when we was talking about the safety profile of the vaccination. Then looking at implementation, if we establish certain target groups, how easy is it going to be for us to get to those groups? And then ethics, we know that there are health disparities, and it's become very apparent when we look at infection rates in certain populations. There are higher infection rates just in terms of the way people live. If people are living in more crowded environments, they've had a higher infection rate. We've looked at morbidity and mortality. We know that certain populations have a higher mortality rate because they have a greater underlying chronic disease burden. And some of that chronic disease is a result of social issues. If folks live in poverty, their physical activity might be less. Their stress levels might be higher. They might be subject to more violence. Their nutrition may be poorer. And that may predispose them to having complications from COVID-19. All of those things have been taken into consideration when developing these phases. So when looking at various populations, knowing what Dr. Browne talked about in terms of production of the vaccine, we had to get a sense of the size of the population in each group. So just looking at what we've been talking about, phase 1A, which are healthcare personnel, there are 21 million individuals in the US that fall into phase 1A. So think about that. We've got to produce basically twice 21 million doses or we have 21 million people that fall into phase 1A and each of them get 2 doses. So just that kind of production needs to take place before we can move into any other phase. So those that are in phase 1B or in 2 are starting to say, when am I going to get my vaccine? There's a very large population in phase 1A that needs to be vaccinated before we can move on. And then we have, in terms of essential workers, and I'll talk about who falls into those categories because a number of your questions ask about specific groups. There are 87 million. We look at the elderly, individuals with high-risk conditions, over 100 million. So it gives you a sense of the challenge that we face as a nation as we try to vaccinate these more vulnerable populations. So here's a little bit of a breakdown in terms of who we're talking about when we talk about healthcare personnel. So we're already here in Connecticut vaccinating hospital personnel, long-term care facility residents, as well as staff. And you can see EMS providers and first responders that are likely to respond to medical calls are all in that phase 1A group, which we're currently vaccinating. So when we get into phase 1B, we start to look at essential workers, and you can see the list there, and I'll give you a little bit more detail in a couple of subsequent slides. So going back to looking at the science, so looking at healthcare personnel, they're very sort of exposed. And as of late November, there were 228,000 healthcare workers in the US that had confirmed COVID-19 infection. And 822 of them died from that infection or complications from having COVID-19. So that's what bumped them up to the top of the list as people who should be vaccinated first. They're the most exposed. They are, of all of the employment groups, the most infected and the highest death rate. Right? And obviously, in terms of implementation, it's pretty easy to vaccinate healthcare workers because they're in settings that we can actually facilitate vaccination. So again, these are the kinds of things that were considered in developing the phases and deciding who goes first, right? One of the things that we talk about is in terms looking at infections, there are more infections in the 18 to 24 population than any other age group. You know, Mayor, we've heard a lot about COVID-19 spreading in hospital campus, on college and university campuses. You can see it in this data right here,
Correct.
right?
Yep.
But if you go to the next slide, you can see that the mortality rate is very low
Right.
in the 18 to 24 population. So lots of infections, but few complications and thankfully, very few deaths.
Right.
So going back, you look at the number of infections in the elderly population, they're certainly significant, and especially in the 80 plus, because there's been a lot of infection in nursing homes.
Right.
We've heard about that even in our own community. But look at the mortality rate, right?
Yeah.
For folks that are, 65 and older, and once you get to the super elderly at 80 plus, the mortality rate is extremely high. So that's why the decision not to vaccinate 18 to 24-year-olds in the 1A group, but to vaccinate those in nursing homes first in 1A.
Right.
So it's hard to argue with the science behind those decisions.
Right.
Hopefully my colleague, Dr. Browne, would agree. And just recently, although an early recommendation was to not include include those over 65 in phase 1B, the decision was made just before Christmas to say the next phase after healthcare workers would include those 75 and older.
Okay.
Now, the question, Mayor, that you've asked is, well, how are we going to get to those groups? So remember, the CDC subcommittee is making recommendations, and then it's up to the state. And as of yesterday, the state has not decided on its approach on how they're going to vaccinate anybody in 1B. So those over 75 and essential workers, there isn't a vaccination plan just yet. So even though Griffin is one of the largest vaccinators for the 1A population, we haven't been instructed yet how we're going to begin vaccination for the 1B population, which is going to include the elderly. Now, again, in nursing homes, they're already being vaccinated. The federal government is contracted with CVS and Walgreens to vaccinate all nursing home personnel. That's both residents and staff here in Connecticut. So that's already begun. But the 75-year-olds, I guess a question to ask is, should that be done in senior centers, in congregate housing? Should we be expecting those people to drive to the hospital? Is that even practical? So we've got to come up with a thoughtful approach in how to do this to make sure the implementation is effective.
Yeah. Very good.
All right,
Okay.
well, so go ahead.
Go ahead.
No, I was just going to say there is an information system. Let me just jump forward again, because the next group you wanted to know about is essential workers.
Right.
So the phased approach, when we get to essential, so after hospital personnel and those in nursing homes, this is the group that is considered phase 1B. This is going to be who goes next.
Okay.
All right. So right now, first responders that are likely to respond to medical calls are in phase 1A. So at Griffin, where we're vaccinating phase 1A, we're seeing EMTs and paramedics. We're seeing fire department personnel that respond to medical calls. The next group includes teachers,
Yes.
right? Grocery store workers. That was one of your questions.
Yes.
But what we don't know right now is what the rollout plan is to phase 1B. What we should know in the next couple of weeks. So going back, I think I have a slide that shows you the schedule on the likely schedule for those. So we're in phase 1A right now. The federal government is thinking that phase is going to take about 6 to 8 weeks. So at let's call it week 7, we'll start phase 1B. Now, we've only been at this for a couple of weeks now, right, Lisa? So
Correct.
realistically, you're thinking about 5 weeks from now, Mayor, where we would get into that phase 1B that we just talked about.
Okay. I see that. Okay. Next question, maybe for the doctor. Are we over the second peak?
So we still have a lot of patients that are positive.
Yeah.
We're still seeing, we are still seeing an increase. I know Patrick was going to show. There we go.
So you can speak to that, Fred. Those are the
Yeah,
number of,
absolutely, absolutely. So, and I was gonna actually, we have this in mind. So, interesting enough, this is a graph that demonstrates the amount of positivity that we're seeing in the community. So, in the actual state. So, this is actually very telling. And remember, this is positivity. So, this is many people that are positive. And again, this doesn't determine their, how sick they are, how well they are, if they're asymptomatic or not. All this is actually how many have actually tested. This is actually a good sign. And just sort of as a side note, this is a good sign. As we see an increase in positivity, we actually start to see an increase in hospitalization. Based on early data related to the illness itself, we do know that about 95% of the people who get infected with COVID-19 really do okay. They're managed, and from my standpoint, that means they're managed at home. About 5% are sick enough to go into the hospital, and about 1% are the ones who get really sick and potentially are put on ventilators. So that's sort of the rough numbers that we're dealing with. So the question is that are we seeing a downturn? Are we ending the second wave? Well, the hope is yes. The bottom line is we won't know until really next week, because a lot of this positivity had to do, and I think this goes back to Patrick Charmel's slide on who was getting infected. And we noticed that there was a lot of college kids. And I can tell you that sort of along my theory, and probably makes some basis, is that, the college kids went back to school. You know what, they were relaxing a little bit. We had sort of a mild summer related to COVID-19, as you can see in this graph. They're like, oh, it's, don't worry about it. This might be a little bit hyped up. We know how we were in college, right? So,
Yeah.
So maybe not wearing a mask, not socially distancing as much as they could have, a couple parties together. And then all of a sudden now they're going home. And as they go home, they end up infecting families. Maybe there's parties like in Halloween. I could tell you, at least in my town, there was a lot of parties going on. I didn't see a lot of masks that were being worn, and they start to spread that. So again, these isolated cases were now going to families. So we started seeing sort of isolated cases to families, and then we started seeing these numbers sort of uptick. And that was sort of the beginning of the second wave. The second wave has been longer than the first wave. The first wave was a huge spike, hit a lot of nursing homes, and patients were really sick. This one, we've seen people who are sick, but not as many. We've seen a lot of people who have been in that sort of 95 range, where they've gotten ill, but they've resolved and they're doing better. So when I say I hope we're done, is that we know that Halloween and Thanksgiving probably boosted up that second wave a little bit. Since we just had Christmas and Hanukkah, the question is that if people were being appropriate, wearing their masks, washing their hands, and socially distanced, then we might be done with wave 2. If they did not, this could mean that we could see an uptick. And as I said, we might start seeing that next week, and then the week after that, we'll start being hospitals. So my fingers are crossed that we're not there. I don't know if we necessarily call that a third wave, but that's going to be where we are. But we just haven't had enough vaccine out there to really curb the ability to spread this highly infectious virus.
Okay. Well, that brings me to this question that has been asked. Are masks with us for the long haul? And do you see masks and social distancing impacting the spread of the flu and seasonal colds and viruses?
So I think, honestly, I think at some point there will be sort of a release of masks, but I think it's going to be a long time. If you think about how many people need to be vaccinated just to get to the point where we're not worried about this virus, it's going to be a lot. I think people have also realized that wearing masks, washing their hands, and social distances has actually kept a lot of the other viruses down. We've had probably one of our lowest flu seasons that I can remember. So the flu is down. If you think about it, Mayor, I mean, how many people do you know who have the common cold, who have,
Right.
an upper respiratory tract infection,
Right.
even a GI illness? It's really low if you think about it. That's
Yep.
been really low. So I think there's a new age. And again, an infectious disease doctor, I've actually never heard it as 2 decades, but that's starting to make me feel a little old.
Yeah.
An infectious disease doctor for 2 decades, I can tell you that this is now the top of people's minds. And now people are starting to think of infectious diseases. People are thinking more and more about transmission. People are thinking about, if I touch this, I'm going to potentially get that. And I think that's important to kind of keep in the back of their mind. So I really do think that there is going to be, I think the mask is going to continue on for a period of time until we can get enough people vaccinated. It will start to go to the wayside. But then the question is going to be is, if people choose not to get the vaccine, are they going to need to wear masks,
Right.
For their own protection? And I think those are the questions that we're going to have in the next, and again, 6-8 months.
Well, that brings up the next question, which you just mentioned, is there any discussion relative to mandating the vaccine in either the private or public sector?
Yeah, I could take that one. So there has been a lot of discussion about that. Griffin was sort of a leader amongst hospitals here in Connecticut in mandating vaccination for the seasonal flu years ago. So you can make a very strong case that hospitals should be mandating vaccination for COVID-19. There was some question whether there was a legal basis for that. New guidance was just released last week, just before Christmas, I guess the week before, on December 16th, from the EEOC. And the new guidance is suggesting that employers can require employees to receive COVID-19 vaccine as a condition of returning to or remaining in the workplace. So there are legal grounds for it. Then it's going to be up to individual employers as to whether they want to enforce that or not. Obviously, there are going to be human resources implications to do that. There is still some skepticism about the vaccines, most of it unfounded. In a healthcare setting right now, if you said it's mandated at Griffin, and we had 30% of the workforce that refused to take the vaccine, and in some hospitals it's higher than that, what are the consequences of that? We wouldn't have enough caregivers to care for patients. On the other hand, we don't want to put caregivers and their family and the folks that are exposed to them and their family and the community at risk. So it's a real dilemma. But the answer to the question directly is the EEOC is currently saying that employers can mandate vaccination.
They can. Okay. Next question is, what is the cost associated with the vaccine? Someone had asked.
Yeah, so I can talk about that. So there is a cost associated with the vaccines that is being borne by health insurers, but health insurers are prohibited from imposing a copay or deductible on vaccination. So there'll be no out-of-pocket expense for consumers.
Oh, that's good. Good.
And I know that those that are uninsured, I'm pretty certain at least the hospitals in the state, and I suspect that the community health centers that are administering vaccine will provide the vaccine free of charge to those that are uninsured.
Okay. Will there be a vaccine clinics available on weekends and weeknights?
So currently we're vaccinating phase 1A. I talked about that, right? Which are sort of healthcare providers.
Yeah.
And we're doing vaccination clinics here at the hospital 7 days a week and up to 12 hours a day. Again, the state has not provided guidance yet for the subsequent phases,
Right.
but in all likelihood, those that are vaccinators will be offering weekend and evening hours for vaccination. Lisa, do you think that's fair? Lisa is our vaccination content expert.
Yeah.
Oh, sure. Yes, they definitely will be available. And as more vaccine becomes available to the general public, they will be rolling these out to your local pharmacies, other health departments, and things like that. So there will be more opportunity for vaccination. And just as an example, this slide depicts there's a software that the CDC has created to help manage these appointments and the vaccine administration record. And when Griffin first started this, if I typed in, the zip code for Derby, the only area that I could get a vaccine in was Griffin Hospital. And as you can see, as of late, there are several other health departments and some of the other local departments that are offering vaccine clinics. So I expect, and that's just in a matter of a day or so. So as more rolls out and more people get enrolled into this VAMS program as vaccinators, there will be more and more opportunity for all to access vaccines.
Dr. Browne, you may want to comment on our local health department because I know you've been in close contact.
Yes, so we've had regular contact with Jess Christie and sort of her next steps. We know that next week they're going to be doing a soft rollout and they're going to be getting their set of vaccines. So they're going to be working on starting to vaccinate. They're also focused on the 1As, so they'll be working with us to vaccinate the 1As. And then she's going to progressively increase the vaccinations through the health department. She's really looking forward to that. I think she's getting her nurses vaccinated. She was vaccinated last week. So I think we're getting to that phase. So again, I think there's going to be more and more of an ability for people to get vaccinated, again, once we get to that 1B category and moving on from there.
Okay. All right. Will testing continue to be readily available in 21? And do we anticipate that the vaccine will control COVID in 21, where we can move into a phase 3?
Fred, you could take that. I'll add some color on the testing, but you've got a good sense of the trajectory of the pandemic and getting it under control.
So let me talk about herd immunity and maybe mention that because I think that really helps. So you've probably heard different numbers about herd immunity and I can even give you sort of a quick update what herd immunity is. So herd immunity is the ability of a group of living creatures, hence the herd, a group of living creatures in which an illness can spread, in this case, a virus. So what happens is that if the herd has never seen the virus, and we'll stick with the virus in this one, then anyone from that herd can get sick. As the herd gets sick, and survives, they need to survive. If they don't survive, that doesn't really help with herd immunity. So once they get sick and then they resolve, then the next time that virus comes in contact with that herd, then it's harder to spread it. So if you can imagine if you go in contact with someone and they've already had it, you can't spread it to them, and therefore they can't spread it to anyone else. That's the basic premise for herd immunity. The more in that herd that have actually either developed antibodies secondary, so that's the immunity, antibodies secondary to natural exposure, or if they've received exposure to, or they've actually received a vaccination. So vaccination is really a synthetic way of doing herd immunity. So the more people that get vaccinated, then the more likely that you won't be able to spread the virus. In combination, the numbers have been as high as 80%. That's a combination of both those who've been infected as well as those who've actually received the vaccine. If it's just the vaccine, I've heard numbers closer to 40% of the population would have to get the vaccine. So again, I think if you want to focus on that 80%, Mayor, that kind of gets you to the point where 80% is a lot of people to actually truly have
that
herd
was one
immunity.
of the questions. That's one of the questions was asked. What percentage of the population needs to be vaccinated to obtain herd immunity?
So once we get to that point, and once we've all been vaccinated, and again, this is a very good vaccine. Once we get to that point where we've been vaccinated, we have antibodies, COVID's going to be over. I mean, if a new virus comes there and it doesn't run into someone who has already had the vaccine or has already had it, then it can't spread anymore. And it actually goes into an area where, and it's interesting because there's a lot of epidemiology and epidemiologic statistics associated with this that basically shows that once it gets below a certain number of people who have actually been vaccinated, below a certain number of people who have the ability to get infected, then the likelihood to spread is almost zero. Now, granted, those who don't get vaccinated, who chose not to get vaccinated, they could still be at risk in the community, but then it's almost like personal risk. They would have to run into someone who was infected and then someone who's never been infected, never been vaccinated. And that sort of That's sort of what we're talking about. So there is going to be an end. I believe it will be. Again, this is sort of personal opinion. That'll probably be, we're going to, as this vaccine goes down, we'll hopefully see less and less people get infected. My hope is a limited mask summer.
Yeah.
We'll have to see how it goes.
I agree, Doctor. And Pat, did you want to add?
Yeah, so if you just go back to the graph that we looked at before, we were kind of focused on 1A and 1B.
Right.
Trying to figure out when we get to 1B. But look at this, we're talking 20 weeks before we even get through all of phase 1.
Right.
And that gets through adults that are high risk and adults over 65. So that's not getting to younger, more healthy people.
Right.
So we don't really have herd immunity until after phase 1, when you're well into phase 2. And that's more than 20 weeks from now. So we have a long way to go.
Yep.
And so the testing program, although we'll probably stop testing in the nursing homes, probably in late February or March, because remember, they're being vaccinated right now, staff and residents. Our public testing in the community, and Griffin is testing here on campus at our drive-through testing center and 4 other locations throughout the state. Right, in Farmington, right, in Monroe, in Middlebury. So those will probably continue well into the summer.
Okay. A lot of these questions, Pat, you answered, and Doctor, you have answered, and Lisa, you have answered. I'm looking through. Okay, how do we know the vaccine works? Was a question, Doctor.
So interesting enough, the science that has been done to get us to the point, and what we do is we actually do controlled studies. So what it is we've actually done them. So again, just not to go too much into the details of how we do studies, but the initial phase is that what does it look like in animals? So we've actually been dealing with this in animals for quite a period of time. It looks really good in animals. It looks like it lasts for a while and definitely confers immunity. The second phase is that humans, is it safe in humans? And then we do actually a controlled study. So we have those who actually have those who have received the vaccine and those who haven't received the vaccine. And we've been able to take those numbers. And again, not only is the science really good, but our ability to do mathematics is much better than it's ever been. So we can actually calculate and statistically measure what this looks like in the future. So the amount of people who've actually received the vaccine versus those who didn't receive the vaccine show that there's statistical significance in getting the vaccine versus not. And this is where you hear the terms like with the Pfizer vaccine, after you get the initial dose, it's 54% effective. So that means that the likelihood that you're going to get an infection is 50% less, right? If you get it the second dose, the booster dose, 95%. So that means you have a 5% chance of actually getting an infection from it. So you can see that, and that was based off of controlled studies, people who had it, people who actually got the vaccine versus people who did not. And that was, almost 100,000 people that we actually do that. Now we're going to continue to monitor that studies as we go in, and this is after the vaccine's being used. But I feel very comfortable both in the science that we talked about earlier about producing these proteins, the natural immune response we have to proteins, and the data that we've seen out of Pfizer and Moderna. All of these are very, very encouraging that this is going to be a very good vaccine. In fact, this is deemed to be one of the best vaccines we probably ever made because it's so effective and because it's actually producing proteins as opposed to us actually injecting proteins. So again, I feel very comfortable that we have a very good vaccine here.
Well, what about are there side effects that you've been seeing, Doctor? Any side effects from this vaccination?
There are, and we're always, right now we're in phase 1A. We're also in initial injection and not booster injection. But we are seeing minimal side effects. The minimal side effects is arm soreness is probably our biggest side effect. And honestly, that's not all that terrible.
That's not bad.
It's not bad at all. So a little bit of soreness in the arm.
I'll take that.
Yeah, exactly. And then even if you look at it before we started using it, there's a 10% risk of getting headache, diarrhea, body ache, and low-grade fever. But that's pretty low, and it doesn't last very long. I think we've actually seen maybe some of our, some younger people who've received it maybe get a little bit of that, but honestly, it's really not much. So I can say with a lot of confidence that we've seen minimal side effects. As for anaphylaxis and the other things, I know
Right.
Mr. Jaser talked a little bit about that.
Mhm.
And honestly, it's just as much as you would expect on any vaccine.
Right.
That's just sort of the nature of the beast. So that sort of just happens. So again, good vaccine, minimal side effects. I think the big question is that, is there going to be long-term side effects? There's no answer to that yet. But it's not looking like it. It's really not looking like it. At least, the people who got the initial injections during the study, it doesn't look like there's been any long-term effects. So again, we don't know long-term, but right now it's looking very good.
Okay. I'm looking at these questions, and you showed a lot of them on the PowerPoint. Vaccines available for teachers, for grocery store workers, for first responders. I think you basically covered that in your PowerPoint.
Mhm.
And then is there one brand of vaccine that is safer than the others?
So I can answer that.
Yeah.
There's no data to say these first two vaccines are basically the same technology, the messenger RNA, as Dr. Browne alluded to. And if you look at the clinical trials that were performed independently by the two different pharmaceutical companies, the side effect profile and the efficacy were very similar. So I would say they're really, even though we can't give you the first dose of Pfizer and the second dose of Moderna, that's not recommended.
Right.
However, if you compare them, they are equally effective and have similar side effect profile.
Okay.
Yeah, there's been some rumors too, Mayor, about this that I just want to dispel. Yeah, the Moderna and the Pfizer, there's been a couple comments along the lines of, there are different volumes. That really doesn't mean a whole heck of a lot,
Right.
because there's also different storage mechanisms related to that. I also heard that people are worried because Moderna is a newer company than Pfizer. That's actually not an issue either, considering Pfizer ended up partnering with a newer company named BioNTech to actually do this. So it's not. So again, I think these are just things that people are nervous about.
Right.
But honestly, the two vaccines, same science, little bit of modifications, a little bit of different storage issues, but clinically they look exactly the same.
At least, can you just, in terms of the volume issue, what that is, so the listeners understand what that really means practically?
Absolutely. So without getting too technical, the Pfizer vaccine is 0.3 mLs. So that's like a tenth of a teaspoonful, tiny amount. And the Moderna is only 0.5 mL. So it's a little bit more than double, but it is such a tiny amount. Anybody who uses insulin, it's less than a 1 cc or 1 ml, which again is about a fifth of a teaspoonful. Interestingly enough, some questions I've gotten is the vaccine cold when you get it? Because there's been a lot of talk about the ultra low temperatures that we have to keep this at, and we have to obviously defrost it before we give it to you, and then we draw it up, and then it sits at room temperature prior to administration, so it is not cold. But what is interesting is you don't feel it at all. And I've gotten many flu vaccines each year. I get the flu vaccine, and some are a little bit more uncomfortable than others. This, you don't feel anything at all. There's a mild ache in your arm, but when they're actually injecting it, you'd be surprised. I wouldn't be surprised if people say, "Did you give it to me?" Because it really is, you don't feel a thing when it's being injected.
Okay. One last question. Someone asked, how do we know it will be safe in 20 years?
I can answer that question for you.
Yeah,
We don't know. I mean,
I figured that.
I don't know where I'm going to be in 20 years.
Exactly.
I was gonna say, Dr. Browne, can you promise, Dr. Browne, I'll be alive in 20 years?
I'll tell you what, I want to thank the panel, Doctor, Pat, Lisa, thank you for for sharing this. We're going to put it on our Facebook page for anybody who's missed it and they want to be able to see it. We want to thank you for your time. And your presentation was fabulous. So thank you very much.
Mayor,
Thank you, Mayor, for hosting this, and thank you, John, for facilitating it. It's
Yeah.
great. We really appreciated the opportunity to share the information.
Thank you all so much.
Thank you all.
Bye-bye.
Bye-bye.